Ladies and gentlemen, welcome aboard the Pilot Lawyer Podcast. Thank you for your attention while this important legal information is reviewed. What you hear should not replace consultation with an attorney and should not be considered advice for your situation. On behalf of the Pilot Lawyer and your entire crew, it's our pleasure to have you aboard.
Welcome, aviators, to the Pilot Lawyer Podcast with us, the Eisen Brothers at the Eisen Law Firm, where aviation law is all we do. You're here for what we do best, navigating the FAA medical certification process for pilots and those who want to become pilots. Around the office, we say, if you don't laugh, you cry. And for the next 30 minutes, we hope to bring you the lighter side of what can otherwise be a frustrating process. So whether you're laughing at us or with us or roasting us on the internet, join us, brothers, as we discuss the fascinating world of FAA medical certification. Now, over the last couple of episodes, we've had some distinguished guests on, and we've received excellent feedback from those that have called, appreciating the content that we've been able to actually generate in those last two episodes.
Mainly our mother.
Well, you got to get the feedback where you can get it. So that being said, we have a third distinguished guest with us here today that we hope to provide some additional insight into the psychiatric. Well, maybe he can speak to what's wrong with my brain.
Well, nobody can figure that one out, baby.
Yeah,
We only got 30 minutes here.
That's a tall order.
That's right. Well, today we're going to have Dr. Bascom Bradshaw, a HIMSS-trained psychiatrist, a psychiatrist that we work with quite a bit. We're very excited to have him aboard because he also has a significant military background, and he was as I understand it, consultant to NASA for the astronaut candidate selection program. So I'm going to find out today just why I couldn't become an astronaut.
I'm just looking at you. I can tell why.
They can't even find a rocket that can get this much payload off.
BMI above 35.
Too much mass to leave the Earth.
Too much payload.
Might as well just shoot the Earth into orbit.
That's right. Well, let's see if we can't get Dr. Bradshaw on them, see if he's going to even answer this call.
If he knows what's best for him, he probably won't. Here we go.
Good afternoon, Dr. Bradshaw. How you doing?
Good afternoon.
Yeah. Well, hey, thanks so much for joining us. We appreciate you taking the time out of your schedule to be here with us. So kind of what we typically do with our litany of two guests so far, we ask you to just kind of introduce yourself, tell us what you do, where you do it, and stuff like that.
Sure. Absolutely. I'm an aerospace psychiatrist, board certified in psychiatry. And while there's no fellowship training currently for aerospace or aviation psychiatry, I do have a background in aerospace medicine, previously residency trained and previously board certified, allowed those boards to lapse since I've been working primarily in psychiatry for over the past 14 years. And I work out of a home office based in southeastern United States in Dothan, Alabama. I ended up here after my last duty assignment in the U.S. Army. I was the chief medical officer for the U.S. Army Air Medical Center at Lister Army Health Clinic, and I had some dual responsibilities of providing largely the same types of consultations I do now with regards to the FAA and HIMSS psychiatric evaluations. And so that's pretty much what's put me in this location where I currently am. And I also do some inpatient psychiatric work just to kind of keep myself involved in acute inpatient psychiatric care, which I believe kind of best positions me to see individuals that have acute psychiatric issues when I'm looking at individuals that either previously experienced those types of issues or perhaps maybe some of the more stress-induced or stress-related types of conditions I oftentimes see with these evaluations.
Hey, Dr. Bradshaw, this is Christopher, and we previously had you as an expert witness in a trial we were getting ready for, and
Sure.
So I've had an opportunity to look over your impressive CV, and I know there's something on there about you having worked with NASA. Is that correct?
I've done some, periodically they do reach out for contract outside consultants to help out with selection. And certainly that's part of a long process in which the individual, the astronaut or potential astronaut candidate goes through the medical evaluation medical selection process. And part of that is the psychological and psychiatric evaluation. So certainly I have participated in that process previously at Johnson Space Center. And a lot of what that involves is structured interviews where, as a psychiatrist paired with a psychologist, conducts a 3-hour interview, 1.5 hours of which is the psychologist doing interviews that are largely looking at what they refer to as select-end types of factors, and as a psychiatrist from a diagnostic standpoint, looking for things that would be rule out, if you will, types of situations with regards to psychiatric conditions or history of psychiatric conditions and things along those lines. And so
cool.
Certainly makes for a long day. And,
I bet.
But certainly a rewarding process, and ultimately it leads to a recommendation, much like, disappointingly as a physician, you really don't make a lot of decisions. You make a lot of recommendations. And so not unlike my role in the military as a battalion or brigade flight surgeon, I'm ultimately providing a recommendation to a commander who's either going to take that advice or push that advice aside and say, we know better based on what we know about this individual. And so that's kind of how that process works. It goes to a board, a larger board made up of various individuals to include, astronauts, controllers, administrators, things like that ultimately make that decision based off of our recommendations.
Very cool. Well, Anthony's always going on and on around the office, and anyone that'll listen to him, how he wanted to be an astronaut. So
It's these darn congenitally weak ankles. That's it.
the ankles are weak because the belly is large. But
Confucius say.
I want to say from epidemiological studies, weak ankles has been one of the top factors and the shortened future of a lot of individuals seeking to become an astronaut.
Hey, see, I got a credible claim then.
Sure.
Although I imagine it would have been a short day of evaluations if we were on the list of evaluees. Is that the word?
Couldn't even get your name right.
Yeah. Dr. Bradshaw, you certainly have an impressive history, resume, and now you're adding this podcast to the list, so that people will really be impressed. But nevertheless, so today we thought we'd sort of discuss some of the things that our clients and potential clients and people on the street tend to ask us when it comes to psychiatric matters, when it comes to FAA medical certification. So we'll just kind of walk through that with you a little bit and kind of see what you have to say. But if in your practice as a HIMSS psychiatrist and so on, what kind of conditions do you tend to evaluate and assess there? I think you kind of gave us a good taste of it just a minute ago, and who do you do it for? Is it all pilots, general aviation pilots, commercial pilots? What kind of bag is that?
Sure. Yeah, we're pretty even mix across the classes of medical certificates, and certainly with a pretty broad range of individuals from initial medical certification, looking to start flying, whether recreationally or just wanting to seeking out private pilot's license, to individuals that are looking to launch a career in aviation, to individuals that have already been well established in their aviation careers and now, because of some sort of acute life stressor or onset of some sort of psychiatric symptoms, requires them to get evaluation, or perhaps even substance or alcohol related issues. And so I see a pretty broad array of individuals in my capacity as a HIMSS psychiatric evaluator.
Okay. And that sounds kind of what we've experienced here. We send folks to you all the time with an assortment of conditions that they may have a history with.
Sure.
I'm sure you haven't listened to the last episode because not many people do, but we had Dr. Dennison on. Had Dr. Dennison on.
He thought he was on the Howard Stern show at first. Much to his disappointment.
Poor guy.
Yeah. But quit interrupting me.
Okay, I'll be quiet.
So Dr. Dennison's, of course, a HIMSS neuropsychologist.
Mm-hmm.
And I think we've hammered this point pretty clearly in the past 2 episodes, but what do you do differently as a psychiatrist from a neuropsychologist as far as like what an evaluation would look like?
It's funny that you asked that question because I really thought that each of us had a better understanding of what our role or how we were different from each other. But what I've come to realize after some short discussions with colleagues at some professional meetings, conferences, most recently at the Aerospace Medical Association meeting this past May, that a lot of times, particularly physicians, but I think also neuropsychologists or psychologists, even clinical psychologists, fail to recognize what role each of us have in this process of evaluating aviators, or for that instance, any sort of occupational evaluation for individuals that are returning to duty for fitness reasons or whatever it might be. So we're not providing mutually exclusive evaluations. I view these as largely complementary, much the same way that a physician assistant or nurse practitioner is not a physician. There may be some things that are similar in nature to how we conduct our evaluations. How we approach that evaluation is going to be different. And so as a psychiatrist practicing in a field of medicine, psychiatry, I'm going to be evaluating the individual from a different perspective than a neuropsychologist will. And so as a physician, I'm looking at all of the potential rule outs that could explain why an individual may have presented with the signs and symptoms that they may have had for either a transient or sustained period of time in the past or currently. So whether that's medication-induced, substance-induced, psychiatric symptoms secondary to a general medical condition that they may have had that's now been treated. And then looking at the primary psychiatric disorders from more of a diagnostic standpoint. And what continues to be, I suppose, disappointing as a psychiatrist or anyone working in a mental health field, we're still largely working in the realm of the nosological or categorical framework of describing things and describing them not only how they present, but also from a functional standpoint. How does this impact your life and the various domains of social, occupational, academic, things like that? And as a psychiatrist, largely we're thought of as making formulations or assessments and then thinking about how to approach that from a psychopharmacological standpoint. And certainly that's true. And certainly we're able to evaluate that aspect as well, how they've previously been treated, the necessity of that treatment, more importantly, diagnostic accuracy, and then the prognosis for that individual based off their past history and how they're currently presenting to us. And this doesn't vary too much from the neuropsychological or psychological evaluation from the standpoint of we're both doing clinical interviews. But the additional piece from what, I observed from the neuropsychological evaluation is they're also doing a lot of testing from the neuropsychological realm of cognitive testing to include the COG screen, as well as psychological testing. And that provides a window into that individual's brain functioning as it compares to a large sample of individuals that have also taken those tests. And so there's large amounts of normative data of previous pilots, airmen, individuals that have taken those tests by which we can compare those individuals and then make some sort of comparative type of statement with regards to how the individual performed on that particular day at that particular time and those set of conditions, which hopefully are fairly standard. And the neuropsychologist, much the same way as a psychiatrist, I look at their summary and look at the testing. We have to make some sort of clinical correlation based off of those test results, because the test results in and of themselves do not make a diagnosis. They provide additional information that help guide our evaluation. And so much the same way we maybe draw labs as a physician or order neurodiagnostic testing like brain imaging, whatever it might be, we have to draw some sort of correlation with how that individual presented, because the test alone doesn't make a diagnosis. So, to put it in short, I'm looking at from a diagnostic standpoint using structured and unstructured questions, gathering medical history, psychiatric history, social history, their ongoing chronic medical issues and their current medications or use of over-the-counter herbal supplements and things like that, or perhaps their past, recreational use of substances, trying to draw some sort of picture from that, much the same way a neuropsychologist is adding to that by saying, not only are we looking at their history, but we're also looking at their current brain functioning from how they perform on these tests.
Understand. Well, that is probably that's going to reshape, that answer is going to reshape, certainly how we present it to clients. I mean, because, I can't tell you how many calls we field with the question of, what's the difference between a HIMSS neuropsychologist and a HIMSS psychiatrist, because the FAA will blast these letters out saying, oh, you need a HIMSS psychiatric evaluation, you need a HIMSS neuropsychological evaluation. And I think interestingly from your comment here is that, the FAA doesn't typically, at least in their boilerplate letters, prescribe an order in which the evaluations are to happen, right? In certain cases, maybe they've asked for both evaluations, and in our practice, we may get them one and tell the FAA that's enough. But there are other protocols where, both evaluations are required per the FAA protocol. But I think kind of what you're saying, don't let me put words in your mouth, but perhaps having the neuropsychological evaluation before the psychiatric evaluation at times could help inform your evaluation more as sort of a data point that would help the psychiatric evaluation. Is that a fair?
Yeah, it helps. It helps. That's how it's presented at the HIMSS seminar. Ideally, it is nice to have the neuropsychological testing prior to the psychiatric evaluation, but certainly there's, and that's how it was done in the military as well. If an individual is going through some sort of a medical evaluation board, or even in certain instances for air medical waivers, when we're looking at pilots to return to flight, or individuals that are applying to go to flight school. But there's certainly I wouldn't say that it necessarily adds to the pretest probability of an individual having or not having some sort of significant impairing or disqualifying condition per se. But, while I'm providing a recommendation as they request, per their outline of expectations for the evaluation, really ultimately we're providing our observations and recommendations to a larger body that is going to ultimately make their decision. And so they have the ability to look at that neuropsychological evaluation as well as my evaluation or any psychiatric evaluation and draw conclusions themselves, if you will. It's almost like a peer-reviewed journal that requires an individual to submit all of their data. They're going to look at your paper, but they're also going to look at your data as well. And they're going to have someone there at the journal that's going to run the numbers on that data to see if they draw similar or, some sort of diverging conclusion.
Dr. Bradshaw, you kind of brought up an interesting point, or you said something that piqued my curiosity, and I guess that's enough to ask often. A question. But, given your military background, and presently we're seeing an influx of cases where the FAA is pursuing, it's kind of crazy what they're doing, but long story short, they're looking at airmen that are receiving VA disability benefits that also hold medical certification. And, one of the big issues that we frequently see in these types of cases is where the airman has a disability benefit for PTSD. Could you talk to us a little bit about what you're seeing in those cases and
Sure.
whether or not those people are, in your opinion, able to hold a medical certificate despite having a history of PTSD?
Sure. Yeah, it's an interesting situation, and certainly we're coming out of a lengthy period of high operations tempo in which lots of individuals, particularly air crew, but not just air crew, because I see a lot of individuals that were prior infantry, riflemen, service support type individuals working in support roles that may have not had direct contact with combat, but certainly had seen some of the peripheral types of effects and stressors that one sees in a combat theater. When I first became aware of the situation where they're running that interface between those databases, I've heard this whole situation described a number of ways by airmen or applicants, that have been somewhat disgruntled by this, but I've heard really good explanations from psychiatrists from the FAA with regards to the purpose behind this exercise, if you will. And it's not that they care about individuals drawing VA disability. It's not that they care about the percent of disability that the individual is currently getting. What they care about is flight safety. Particularly what they care about is the individual's condition static, or is it one in which the individual is clinically stable? And if there is any ongoing post-traumatic symptoms, are these easily identifiable? And as the individual either one, currently being followed by someone in the VA or being followed by a mental health professional, or have they received what would be considered the gold standard of treatment, whether that's trauma-based therapy or some sort of first-line treatment for these trauma-related symptoms? Or do they even have PTSD? So, I mean, there's a wide range of situations here in which we now have, I wouldn't consider them predatory. I think they view themselves as being helpful, but there's a large number of organizations out there, for-profit, some nonprofit, few nonprofit, but mostly not for-profit individuals that are trying to assist service members with accessing their military benefits and helping them or assisting them with these evaluations. And certainly the former service member is not, a passenger along for this ride, but a lot of them describe it that way. And they feel like that perhaps maybe the interviews may have been pushed into a direction that perhaps maybe misrepresents, what they felt like they had shared during those interviews, but certainly present diagnostic dilemmas with regards to how to proceed with regards to their now aeromedical disposition, if you will.
Do you see any issues or conditions with somebody that has PTSD that you would say, this is a hard stop? There's no way I can, in good faith, from a medical standpoint, say this individual doesn't have an aeromedically significant mental health issue due to the PTSD?
As an outside consultant that does not work for the FAA, I'm not a decision maker. And so certainly I don't identify really what I would consider a hard stop. I lean into the idea of my background as, a former Army flight surgeon that certainly has spent the majority of my time in my career as a flight surgeon, ensuring that I'm trying to keep aviators and aircrew members flying, while maintaining, safety of flight. But, what I try to do is certainly identify or elicit information that's helpful with regards to highlighting whether or not the individual continues to be symptomatic. And more importantly, from a functional standpoint, are they demonstrating any significant functional impairment in any aspect of their life? And so, while I'm also guilty of highlighting the personal and professional accomplishments and the high level of functioning that many individuals continue to have throughout periods of being symptomatic, we want to ensure that there's no subtle or insidious type of processes at work that may creep into the cockpit and present problems at inopportune times, during critical phases of flight. And so, certainly an individual that's not stable with regards to their condition, and this might be from interpersonal relationships. This may be, frankly, from presenting symptoms, signs or symptoms, or it may be the fact that they haven't sought care at all. And so certainly the idea that an individual has never sought care despite having been identified as having a significant condition, well, that would be a little bit of a red flag. And certainly that would warrant some sort of follow-up to further clarify whether or not this individual has any sort of ongoing issues that need to be addressed. And these are individuals that have access to care. And it's important that we remember that as veterans, that we're not just looking at a disability benefit, but we're also looking at an individual that's going to require ongoing care for a condition that they've been identified previously as having. And so I strongly encourage them to pursue a follow-up with some sort of frequency. And so, certainly that's another aspect of that.
Has your FAA medical certificate been denied? Are you concerned you may not be able to get a medical certificate from the FAA? Are you at risk for FAA action for failing to report your medical history appropriately? Call the pilot lawyer at 1-855-FAA-1215 to discuss your options for getting the FAA to issue your medical certificate and get you flying. We are happy to evaluate your case and discuss with you a plan for presenting your case to the AME or the FAA. Aviation law is all we do, nothing else.
Sort of outside of the PTSD realm to some extent, and speaking to maybe a larger population, but we certainly see this with the veterans as well, or these other mental health conditions that people are being, maybe they're receiving VA disability benefits for, maybe they're not a veteran, they have these conditions and so on. But, Sort of outside of PTSD, we see things like generalized anxiety disorder, major depressive disorder, and adjustment disorders, and so on. Can you speak to how, and I think you have sort of already to some extent, but could you speak to how those types of conditions more broadly might affect aviation safety? Because I think the disconnect that we see for a lot of clients and potential clients, so on, is, well, hey, listen, I don't really have this diagnosis, or I feel fine. I don't know how it's going to be a problem, 5 years from now or whatever. Can you speak to how maybe broadly those diagnoses or history of diagnosis could affect aviation safety?
Sure. So of chief concern is any individual that's been diagnosed with any sort of psychiatric condition that has a relapsing and remitting course. It's easy if it's a condition that presents itself and resolves with the expectation that it will no longer occur. But more tricky are instances to include what was formerly called mood disorders, depressive disorders, bipolar disorder, in which there might be these periods of remission in which the individual appears to be doing just fine, but always presents with the possibility of aggravating factors that might cause some sort of aggravation of that condition, where they become symptomatic, severely symptomatic, which might pose some sort of problem. And more concerning for things like bipolar disorder, where the individual may be hypomanic, in which they're functioning and might be reticent to seek care because they feel just fine, but perhaps they are venturing into the realm of being more impulsive or reckless in their behaviors. And certainly these things
Guys, stop looking at me.
They'll present themselves in some way, shape, or form. The individuals with bipolar disorder are going to either end up on an episode of cops running down the street naked, or they're going to end up, in a hospital somewhere. And so, identifying mania is not difficult. Hypomania, a little more difficult. Individuals with less severe forms of major depressive disorder, perhaps maybe a little bit more difficult, but in these instances where there's a temporal relationship with an acute stressor, after which the individual, no longer has any signs or symptoms with the resolution of that stressor, then, you start straddling into the world of, is this, an adjustment disorder, something along those lines. But to go back to answering the question, as what kinds of concerns do we have with regards to these conditions, is it goes back to really the core principles of what a flight surgeon or an aviation medical examiner should be thinking about or looking for when they're thinking about any sort of medical condition, let alone psychiatric or psychological conditions for special issuance. And that's that, the individual is not going to pose some sort of risk for sudden incapacitation. So for instance, if an individual has problems with panic symptoms or panic attacks, well, that could be problematic, particularly in the flight environment if the individual has some sort of risk for sudden incapacitation. Equally concerning, and perhaps maybe more concerning, is what I was alluding to earlier, is the potential risk for subtle incapacitation, where there might be difficulty in detecting that process is going on that would somehow affect their alertness or special senses or the way they process information, because certain types of conditions, to include generalized anxiety disorder, obsessive compulsive disorder, or even severe depression, can really chew up one's working memory. And we were just talking about PTSD, and while a lot of times we think about the more flagrant signs and symptoms of re-experiencing flashbacks, nightmares, avoidance behavior, I can't be in crowds, things like that, there's a lot of research tied to the emotional experience of psychological trauma and how it has long-term effects on cognition, and how it alters those cognitive processes like memory, attention, planning, problem solving, and things like that. And these things can be highly problematic in the very busy, environment of aviation. And so a lot of these conditions can cause problems that, certainly should be monitored or addressed in some sort of periodic fashion. And so while the individual may be asymptomatic for a year or two, or perhaps maybe several years, to further mitigate that risk, it certainly makes sense to revisit these individuals on some sort of periodic basis to ensure that there doesn't seem to be some sort of resurgence of those signs or symptoms, or, impairment in function as a result of perhaps subclinical processes that may be at work secondary to those conditions.
Right. Okay. I think that's consistent with, in the evaluations we've seen from you and requirements with and other psychiatrists and As far as what the FAA has recommended to folks is with similar histories before, for example, a special issuance authorization in an effort to mitigate risk. Maybe they'll want the airmen to engage with a therapist or something along those lines. But what we've seen... I think, go ahead.
Yeah, I apologize for cutting you off, but I think that it's important at that point to interject, with these various, the two pathways that are available with regards to SSRI, I kind of giggle at times that, I get approached by an airman or an applicant that, has this misunderstanding that if they stop a medication, that somehow that's going to resolve their issue or their problem. And it falls short of the big picture of, the FAA is not really just looking at the medication. While the medication can be disqualifying, it's really the condition that's of more concern. And so while an individual with an appropriately treated condition can be granted a special issuance, an individual with a condition that's disqualifying, that's not treated, or an individual who persistently demonstrates behaviors that are not help-seeking, that certainly poses a problem for that individual. So, it's not just the medication, it's the medication and the condition. And so they're trying to look at opening the door for more medications as there's various types of medications that come on the market that may have lower side effect profiles and things like that are conducive to the aerospace environment. The medication certainly has to be looked at as well, because oftentimes they have aeromedically significant side effects that could, either mask, symptoms that could lead to acute, incapacitation or complications, things along those lines. So
sure. So kind of getting outside of the mental health from like I don't know what I'm saying. Let me kind of move away from those types of conditions and briefly discuss the HIMSS program for substance use concerns. When, as you fully aware, maybe the listener's not, when an airman, of course, matriculates through the HIMSS program for alcohol or substance use concerns, those airmen are always required to be evaluated by a HIMSS psychiatrist. Can you just briefly walk us through what you might look for in those types of cases, which may not be, it may be still a risk, a mitigation of risk for recurrent symptoms and so on, but what kind of nuance would you look for there?
Sure. So typically when I become involved in these cases, the individual, particularly the professional pilot, has already been engaged in some way, shape, or form with some sort of residential treatment or perhaps intensive outpatient treatment or both. And they might be in a phase where they're now entering some sort of aftercare program with peer monitoring, peer support, things like that. And, this has been a program that's been around forever, that's been largely tested and tried and true. And, it's been successful in returning a lot of individuals to flying. And, with regards to looking at markers for success or looking for individuals that present, lower risk in that flying environment, certainly is going to be an individual that's compliant with the monitoring as it currently stands. And while it may seem rigid and one size fits all, I can certainly see, the method and the madness of any deviation from these mitigation measures, certainly in and of themselves, can be markers for relapse risk. And, so when you think about individuals, they're going to pose a higher risk for relapse. And so with these evaluations, the initial one makes a lot of sense. I think I can see from the perspective of a pilot that has just gone through the acute trauma of being identified as having an alcohol-related event like a DUI or some sort of medical event that prompted acute treatment. And so certainly I can see where they can feel like, okay, this makes sense. I do need to be evaluated, from a neuropsychological standpoint, making sure that my brain health is good. Sure. From a psychiatric standpoint, exactly where do I stand with regards to my history of substance or alcohol use and what things look like now as far as maintaining sobriety. I think where it gets a little more elusive for most individuals is when they start to get a few years out from that last incident, and they're kind of wondering, why am I still requiring screening? Why can this not be stripped away? Is that, we think about from a disease model as this being a lifelong type of illness in which relapse is imminent, right around the corner, potentially at any point in time, in which the individual is presented with acute life stressors. And these things do happen. Divorces happen, financial stressors, potential bankruptcies happen, because of unforeseen medical events, life events, whatever that might be. And so these are when these individuals are most vulnerable to relapse. And so during these evaluations or follow-up evaluations, I'm not only looking for compliance with all of the prescribed aftercare, peer monitoring, chief pilot reports, participation in peer support groups. Typically I think they cite, at least twice a week or some sort of ongoing participation to include a sponsor. And certainly they've opened the door to non-12-step types of peer support, which, many people have embraced, whether that's, that SMART program or whatever.
Right.
But I'm looking at things like problems with complaints of not being able to think clearly, memory problems, emotional hypersensitivity or overreaction. Now, I don't know if you've ever heard the term dry drunk, but these are individuals that are sober, but they're not necessarily actively engaged in that sobriety, or they have not been able to adequately cope with their sobriety. So you might still see some difficulties with emotional regulation, sleep disturbances, or there might be some subtle sequela from a neurological standpoint that the individuals may also be suffering. And that's what leads to some of the necessity of re-engaging these individuals, particularly if they're having difficulties with, maintaining currency or showing even some soft neurological signs during their neuropsychological testing. And so constantly monitoring these types of things during these reevaluations that are just a portion of that maintaining active sobriety and maintaining their ability to continue flying.
Right. That's a good explanation, I think, for the listener, especially those that get caught up in this nuance to some extent. You touched on this a little bit. The regulatory requirements for substance abuse and substance dependence are different from a substantial standpoint, I would say, than from the DSM standards. And so
a lot of these individuals have comorbidities with other primary psychiatric disorders, whether it's anxiety, untreated depression. And so, certainly that's, the other reason that HIM psychiatrists are involved, because, we're also actively monitoring for any signs or symptoms that might be suspicious for another primary psychiatric condition.
Sure. That makes sense. And I think to that end, we'll typically see cases where an individual maybe has, for example, been sent to a psychiatrist for an assessment on PTSD, and then their records will reveal that, maybe there was a period of time where there has been a heavier amount of alcohol use, in their history. And then it sort of morphs into this alcohol inquiry that maybe started with PTSD or some other type of condition. But to that end, if, somebody came to you as a HIM psychiatrist and your opinion was that the airman should not be, considered eligible to hold a medical certificate, and that was your recommendation, can you walk us through what types of evaluations or reevaluations there may be from there, at least on this side of the FAA, rather than what happens internally at the FAA? But because I think in our practice, one of the more, maybe, I'm not saying psychiatry is subjective, but it seems like that is, if we're going to get a second opinion, it's typically, comes from the psychiatry type conditions rather than like cardiology and so on. It seems like there can be varying of opinions there. So can you kind of walk us through what that looks like?
Yeah. So, this kind of goes back to what we were referring to before about the diagnostic shortcomings that we currently see right now in the field of psychiatry, and this movement towards neuropsychiatry, again, of a biological basis to these disorders. We don't have lab markers. We don't have biomarkers. We don't have reliable biomarkers for conditions. So there's this necessity of triangulating between or looking for some inter-rater reliability, and sometimes, unfortunately, intra-rater reliability, because I've been involved in cases where even the same psychiatrist that diagnosed them with major depressive disorder or bipolar disorder subsequently comes back and goes, oh, by the way, I don't think that they ever had bipolar disorder or major depressive disorder. And despite that, there's been some pushback with regards to the persistence of that diagnosis versus the reality of an individual who may be asymptomatic for a lengthy period of time that's inconsistent with the natural history of that condition. But whereas in cardiology, you can look at objective types of testing, whether it's from an electrical standpoint or electrophysiological standpoint and things like that, where you can look at things with fair amount of reliability or validity in those measures. So in individuals where there might be some concern with regards to persisting or questionable sobriety, the accuracy of the diagnosis, it is helpful at times if the individual has engaged in substance abuse evaluation or at least proactively approached a substance abuse counselor. I veer away from making recommendations because in my role as an evaluating psychiatrist, I'm not in a treating role. This is not a patient-physician relationship. And it's been a while since anyone slipped and called and said that they were my patient, but I quickly correct them to ensure that they understand that this relationship is one of an objective evaluation to determine fitness versus that medical evaluation role of providing treatment recommendations. But certainly the individual benefits from having multiple perspectives, having demonstrated proactive behaviors of engaging in treatment, whether or not the substance abuse counselor subsequently states that they feel like the individual does not meet criteria for substance abuse or dependence at this time, or substance use disorder at this time. It's certainly helpful to have that additional evaluation to provide another data point, if you will,
Sure.
with regards to where they are at this point in time. We see individuals that, particularly with younger individuals, that we don't fully appreciate the developmental psychological timeline of the various phases of life in which an individual may be demonstrating developmentally appropriate behavior of experimentation or making reckless or impulsive decisions that you would expect to see in an adolescent versus an individual in young adulthood, particularly after the age that you would expect them to be neuro intact, from a frontal lobe type of situation versus individuals that may have, like ADHD, where there might be what they consider to be hypofrontality, where they might perpetually have issues with impulsivity and making bad decisions and things like that as far as executive functioning. And so, that's typically where I find it most helpful for these individuals to have additional evaluations, particularly in the substance realm, or having some sort of summary of care from their treating or previous treating psychiatrist or mental health provider.
Mm-hmm. And to that point, as we discussed with Dr. Dennison on the last episode, Dr. Dennison, I think, tended to agree, and he may call in and disagree with me. maybe I'm misstating him, but his perception was that, you need to develop an appropriate rapport with the HIMSS neuropsychologist, before, engaging with the HIMSS neuropsychologist for an evaluation. Do you have any recommendations when it comes to selecting a HIMSS psychiatrist?
So, with regards to rapport, I think it's one from a professionalism standpoint, since this is not going to be a treating relationship, so therapeutic alliance is not necessarily necessary, but certainly there's an expectation of professionalism that, when information is provided in a timely manner, you're able to schedule the individual in a timely manner or provide expectations for how that process is going to work, outlining what this is going to look like, because certainly individuals are very nervous about the evaluation and what to expect. For a HIMSS psychiatric evaluation, much different than the neuropsychological testing, so while there still may be some quote unquote performance anxiety, it's largely an interview that's structured much the same way that perhaps they've previously experienced with their physician or maybe even psychologist as part of their intake when they originally had treatment.
Understand.
Yeah. So, as far as that rapport, it's not going to be, I want to develop some sort of therapeutic alliance. I'm going to be exploring psychodynamic types of trends for this individual and perhaps maybe probing and looking for ego defenses and things like that. Although, it's very curious, particularly with pilots and more specifically with some of the prior military pilots, that you see a lot of behaviors that certainly project a lot about their personality through their correspondence, whether it's, oral, through the phone conversations or perhaps email correspondence or texting and things like that. So certainly all of these things are informative, but while they don't necessarily find themselves, splashed all over the ultimate write-up for that evaluation, they certainly inform a lot about what's going on with that individual. And, what I try to provide is an objective evaluation that outlines temporarily the relationship of their signs and symptoms with whatever may have been going on in their life and how this might be explained from a developmentally appropriate or inappropriate standpoint, as well as ongoing external social life stressors or other types of things that might influence why they may have been presenting the way they did, and how they coped with that ultimately, or developed adaptive coping and their current level of functioning, and how that's been able to navigate through life, if you will.
Right. Well, to that point, and I think that the kind of the first tip there is for people to take away is that, don't be a jerk when you call the him psychiatrist for the first time. I've certainly seen that before. Yeah, that's not gonna end well for you. But nevertheless, maybe not. You said it wouldn't maybe show up in the report, but but nevertheless, kind of the last question for you, Dr. Bradshaw. One of the things the FAA always is insistent upon is that the him psychiatrist review a copy of the FAA's Airman medical file as a part of the evaluation. And one of the things that we do is Alex here is his sole opportunity for him to talk on the podcast, and his job here is to gather records. And so we're always making sure before someone sees you or, any him psychiatrist, that records are provided to the psychiatrist in a way to prepare for the evaluation. But are there any other efforts that you think that you could recommend if you can prepare for a psychiatric evaluation? What would that look like?
No, it's providing the information. Information is paramount. That, I think, single-handedly is one way to absolutely assure that you're going to get a letter in a timely fashion, sometime 6 months after the evaluation, that the FAA needs more information, is if there's perhaps maybe a misrepresentation of something that previously had been provided to another healthcare professional or individual involved in that process. So, not necessarily worrying about being consistent, because, a good evaluation is going to involve a good records review. And so the records are important in order to look at things from a longitudinal standpoint of, if this individual had this condition, then you'd expect to see significant representations of, some sort of clinical phenomena consistent with that mentioned in evaluations by other specialties, when they're talking about their past medical history and things like that. So I'm looking through everyone's notes and looking for mentions about medication or diagnoses that might be relevant to my evaluation, as well as perhaps maybe patterns of presentation of the process by which they've been trying to seek their medical certification, which I largely, I don't want to say assume, but, certainly that's what the FAA is, wanting the individual to be able to see. Has this individual presented to multiple AMEs, or what does this timeline look like? Right. But it's good to be working off the same playbook. So when I'm gathering information for review, for an interview, and ultimately for the write-up, it's best if that information's been submitted, either one, to the FAA, or two, if the individual is working with an aviation attorney. It's important that all of that information in total is presented at once. So the information that the evaluator is looking at is the same as the information that the FAA is looking at, so that we don't find ourselves in a situation down the road where, the FAA or someone at the FAA is scratching their head wondering why, Dr. Bradshaw or someone else is mentioning or citing a document, a supporting document that's not available to them. So we're all working off the same source documents, if you will.
Right. Well, that's a good tip, I think, for people when they're preparing for, is always to have the records there for you to review and well in advance of the evaluation. That's something we always appreciate of your evaluations, Dr. Bradshaw. But that being said, I think this is some of the best content we've had. I think Dr. Dennison and Dr. Servant are going to probably find you somewhere and try to fight you in an alley because you got some really great content here. So we really appreciate you. And Dr. Bradshaw, if somebody, because you're offering a free service here by talking to us today, it's not a paid gig here today. So certainly want to offer you an opportunity to identify, how if somebody wanted to be evaluated by you for a HIM psychiatric evaluation, and I don't know why they wouldn't want to be, how would they find you?
Sure. This is going to sound odd, perhaps, but much like my childhood buddy who dropped out of high school the second time he did the 10th grade,
he's not listening. So.
So he's also a practicing psychiatrist now. He works in the screen printing business in the Dallas-Fort area, but he never advertised he never advertises. It's strictly word of mouth. And, when people need something, they find it. And the one unique, or perhaps not unique, but universal truth of anyone that wants to fly, I don't know what it is, no matter what their background is, what their ideological leanings are, they're individuals that are persistent, they persevere, and they see things through. And so they will definitely find me if they want to find me. So I make it a habit not to advertise, and I won't, certainly, I certainly won't cite my website because, I like to think that I maintain as little conflict of interest as I possibly can, as difficult as that is to do because, by virtue of anyone's interactions and
sure. Well,
certainly
if you're in the witness protection program, you can just tell us that.
I'll leave it like there, but certainly anybody could put aerospace psychiatrist into a search engine, and there's a high probability they may come across my website. So
all right. Well, we'll leave it at that. They can just call us and we'll talk. That sounds good, Dr. Bradshaw. Well, hey, we thank you so much for your time today, and I'm sure we'll be talking to you soon.
Not a problem. I certainly think you guys probably hit a new low today.
Well, hey, no, you did.
Yeah, you're talking about yourself. Yeah. Well, thank you so much, Dr. Bradshaw.
Hey, no problem. Take care.
Well, it looks like I'll go ahead and say it.
You going to say it?
I can
One
see.
of you say it.
Somebody's got to say it.
I can see from afar we're turning base to final. And let me say this much.
How far do you got to be to turn base?
I don't know. Way out here, baby. But let me tell you this much. We learned a lot here with Dr. Bradshaw today. I'm going to put pen to paper, maybe even bust out a few blogs over it.
That's good. I'm going to have to probably listen to this about 10, 15 times before I really understand what's going on.
We know. Just
that one question I asked.
Slow and listen very carefully, and you might get it.
I won't be able to drive and listen at the same time.
You're gonna have to put your speed at like 0.5x so that you can just, when you listen to it,
really slow this down.
Well, that being said, you've logged another uneventful half hour with us. It was certainly eventful with Dr. Bradshaw, so kudos to him for propping us up. Nonetheless, even though our wives deny they know us in public, and now a growing cadre of individuals, Dr. Servant, Dr. Dennison, and we'll add Dr. Bradshaw to it as well, we're the Eisen brothers of the Eisen Law Firm. Have a good one.
This is thepodcastfactory.com.